Hi.
Hi. So I just wanted to thank Dr. Bilsky for coming today. Dr. Bilsky received his Bachelor in Science in Physics, as well as his Master's in Behavioral Neuroscience from Rensselaer Polytechnical Institute. And he received his PhD in Pharmacology and Toxicology from the University of Arizona Colleges of Medicine and Pharmacy. He's a tenured professor at UNE, and he serves as the Vice President of Research and Scholarship. So we're really grateful to have you here today, Dr. Bilsky, to talk to us about pain control.
Yeah. Thank you guys for hosting me. It's nice to see some Unicom alums. I've been at UNE for 14 years now. Basic science. I'm going to tell you a little bit about my life story and how it's kind of changed more recently through contact with providers and also with the patients themselves. I'm going to start with just some disclosures. I do consult and do contract work for various pharmaceutical and biotech companies, including some that are based in Maine. And the university allowed me and encouraged me to start my own biotech companies too, one of which has made it to clinical trials with an opioid antagonist. I'll talk a little bit about that, but again, nothing in the clinic right now for prescribing. I also make the disclosure I am a fan of the University of New England, and we're growing research and scholarship, including around neuroscience. This is kind of a snapshot of us now in 2015. It's a very robust group and includes people that are affiliated with us through all kinds of collaborative efforts. So if any of you are interested in discussing further adjunct appointments or areas that we might collaborate, we're very much open to that. I think that's part of our success has been able to collaborate. So I thought I'd start by telling you how I got introduced or exposed to the field of opioid pharmacology. And it's one of my first memories as a child. I remember that my parents had this cough syrup that was on their nightstand. And I must have had it, they had given it to me at one point. I remember it was yellow and it tasted really good. It was sweet. And so sometime in the late 1960s, I decided to open the cap myself. This was before safety caps, and drink the whole bottle of the cough syrup with codeine in it. Put myself in quite the stupor. They took me to the ER. And this was just at the time that Narcan, naloxone, was being introduced. I guess at the hospital that they took me to, they did not have Narcan, and they just basically monitored me for about a day and a half until I kind of slept it off and kind of came back up. Why I bring this up is that when we have problems, safety issues, we can use an engineering type approach to solve that problem. And so the advent and then wide use of safety caps came very soon after. I think it was in the early 70s. And Narcan was, a great success story. It was rational pharmacology. As they were trying to find non-addictive opioids, they stumbled across these opioid antagonists, drugs that would block the opioid receptor and reverse the effects of drugs like heroin and codeine. So those have made major impacts on safety and saving lives for people. How many of you have been stung by a bee? Who can tell me, from those who answered, what was your first bee sting? Can you remember it? What was it like? Yep. How old were you? Where were you? In
the backyard.
Yep. It is absolutely mind-blowing that you and I remember our first bee stings in vivid detail. I was about 4. I was between oleanders in the house visiting a friend, and this bumblebee landed right here, just like with your palm, right here on this arm and this spot. And I looked at it in amazement. I thought, this is a pretty cool thing. And all of a sudden it stung me. And to this day, I'm deathly afraid of bees, wasps, hornets, bumblebees. So it shows you things that are salient to us, things that make us feel good and things that make us feel bad. We remember. And it's not so easy. If I asked you to forget your first bee sting, you wouldn't be able to do it. Right? Same thing with things that are addiction related. We're tapping into these limbic systems for fear, anxiety, pleasure, and it's not so simple. They become hardwired in, and the more times that these things occur, they presumably strengthen as well, and they become permanent memories. Here's another example. I bet you a lot of you have had broken bones, or you certainly have seen people with broken bones. We expect people to have pain associated with injuries, and if we can visualize it on an MRI, a CT scan, or an X-ray, we can understand it. It's very easy for the general public when they see that person with a cast and the person says, I broke my arm, oh, I feel bad for you. I expect that you had pain. I hope you're better now. It's a little bit trickier we can kind of understand surgery too. I took this off the internet. It is kind of interesting. There's no anesthesiology being administered that I can tell in this picture, so maybe not the best picture to have chosen. But we still expect people to have pain post-operatively, and we have some empathy for those people that have to go through a surgery and then recovery. It gets trickier though when we talk things about migraine and headache. That person's just complaining again. They want to go home early from work. They're always complaining. And then things like low back pain or fibromyalgia, where maybe we don't have a definitive diagnostic that can show us on a blood test or some type of imaging that there's something wrong. And we have to rely upon what the patient is telling us. So this becomes challenging because we really don't know who's faking, who's trying to game the system, and who's legitimate. We have to rely very heavily on self-report and then certainly observation too. So as I went from physics to pharmacology, the transition was because of undergraduate research experience at Rensselaer. And I was lucky. I fell into a lab that was in the psychology department, and they were studying alcoholism. And their goal was to find treatments for alcoholism, not cures, but treatments. And they were fascinated, the investigator was fascinated by the endogenous opioid system. So we make our own morphine-like molecules, the endorphins, the enkephalins, and he was linking ingestive behavior with these endogenous opioids. And there's some good evolutionary biology that said that the opioids were very important when we had feast and famine. During feast, we had to pack on the calories. We had to eat past the point of satiety so that we could survive through the famine times. But that system all got kind of dysregulated with modern humans, that now we could store food and we could have an excess of food with McDonald's and Walmart and CME type events. There's lots of food around. And it seems like the opioids might be maladaptive now. They promote ingestive behavior, especially things that are salty, potato chips, things that are sweet, those cookies, and things that have a lot of lipids, fat in them. High caloric content, bring that in and store it. He made the leap saying that this might also be related to certain types of drinking behavior. And if you think about it, some people who are alcoholics, they drink all the time, 24/7 at a relatively low rate, but because they're always doing it, a high total intake. There's other types of drinkers who binge type drink. And they're the ones that frequently say, I didn't mean to do that. I didn't mean to stop at the bar. I did. I didn't mean to drink 10 beers, but that first beer led to the second, led to the third, and I lost control. And so he started to test this very rigorously. I just came at the tail end of his studies. He'd published on it and put forth a theoretical framework saying that maybe drugs like naloxone and naltrexone might be useful for certain types of alcoholics. And that led, it was picked up by some researchers at Yale and down at UPenn that did the first clinical trials with naltrexone, eventually getting it approved for the FDA. And he was very good, though. He said, this is not a magic bullet. You need to combine this for maximal effectiveness with cognitive behavioral therapy and other treatment modalities to help support the person. If they slip up and they start to have that first beer, it might curb that second beer, third beer kind of craving. And it appears that the literature is bearing this out, that it does help a subset of alcoholics, especially when combined with other modalities. So this led me into the whole drug addiction pain field and pharmacology, and that's where I decided to go to the University of Arizona. And I got connected with a couple colleagues who were studying the opioid receptor at a very fundamental level. And one of the hypotheses we put forth was that chronic opioid exposure changed these opioid receptors in ways that had before not been described. And so we did a lot of work with this, and this led to the biotech company that I'll mention a little bit about. But I had to come out of my comfort zone as a scientist as I was doing all this training. And some of that, and I guess I'm somewhat of an unusual scientist in that I got to see the engineering, the practical approaches. And I always thought all this NIH dollars that we were getting, those were taxpayer dollars, and it had to help human beings, that there had to be some practical applications of the research we were doing. Again, it was maybe my first experiences with that at the RPI labs with the alcoholism. So we identified this metabolite of naltrexone called 6-beta-naltrexol, and under certain conditions of opioid exposure, it behaved differently than naltrexone. we thought naltrexone was inverse agonist. It pushed the system too hard in one direction, whereas 6-beta-naltrexol was a neutral antagonist. It still blocked the morphine effect, but it didn't drive the receptor system too far. Part of the going out of the comfort zone was, how do we get patents? Why do we get patents? We did. We ended up getting patents that formed the nucleus of the company, and that led to further investments, both private and my own investments, the founders, and the NIH has a special program for startup companies. But our goal was to get this now into humans to see if it worked better. And that led to one of two studies that we did in humans. One was a methadone maintenance population, and one was healthy controls looking at its effects, the opiate effects on the GI tract. Another out of my comfort zone was starting to read more widely. Some of that was this landmark Institute of Medicine report that came out in 2011. If you've not had a chance to look at least the executive summary, it's a great tour de force of relieving pain in America. It succinctly says there is a huge problem here. You guys probably already know that, but it really kind of lays out the numbers. 100 million Americans may be in chronic pain. The cost, direct and indirect medical costs, are in the hundreds of billions of dollars, and it's ruining people's lives in a lot of different ways. It's really changing the fabric of society. What's good about it is that it presents possible solutions, a roadmap or a blueprint to start to chip away at some of these things. Some of them are very practical. Some of them are going to take some investments. Part of it's education. This is what we think a university can do. Of future healthcare professionals, we can maybe give them a little bit different perspective, and so they're better prepared to treat these populations. Some of it's also CME with active providers. Part of this is also connected with the humanities and narrative pain medicine, which I knew nothing about. I didn't know what narrative medicine was. But I started, again, I kind of talked with Dan Carr, who's a friend at Tufts, and he gave me this book that he co-edited, and it really changed some of my perspectives on thinking as a basic scientist. I started to have this realization. I had been studying pain at that point, 15 or so years, never had a meaningful conversation with someone in chronic pain. So I needed to change. Get the next slide. Epidemiology. I was not trained. I had some statistical background, but the epidemiology is important. So Maine has some distinctions, one of which is that it's in the highest quartile for opioid prescribing. That's not necessarily a good or bad thing to start, but you have to kind of dig deeper. Why is that? And are there risk factors associated with that high use of opioids? Let's see. Here's another CDC report. Here we are #1, so we can brag. We are #1 in prescribing long-acting opioids. And again, the long-acting opioids are not good or bad by themselves. They can be crushed and the opioids all extracted at once, and that does put people at risk. But we need to get maybe a little bit deeper of the problem. Why is it that we are prescribing these? They may have some advantages too. They may have coverage for 12 hours that allows the patient to sleep through the night. So I thought a little bit more deeply about this. I can get to the next slide. I don't know if you know this, but Maine is the oldest state on average in the United States. And in general, as we age, we tend to get more aches and pains. Our body starts to wear down. So maybe that's explaining some of that. What about this? How about this winter that we just had? Do you think that might contribute to the pain burden with all the shoveling that's going on? Maybe that's in there. I don't know what the ultimate answer is. I think we are overprescribing. We're not necessarily able to have the time and effort it takes to build a relationship with the patient and kind of discuss all the different options. Do the insurance companies reimburse properly for all the different treatment modalities? Are we familiar with them? Is there enough efficacy data to guide us in decision making? Where does the patient come into this? Shared decision making. What are their goals? I'm going to talk a little bit more specifically about some data that supports some of this. And so this one's looking at trends in geographic variations of opioid prescribing. Oops. Sometimes it works really nicely, and then other times. This is another map. This one's looking at defined daily doses of opioids across the United States. The bottom line here is there's a lot of variation state to state to state. Why is that? Is it because Maine has the oldest population? Maybe there's a strong covariate with age of your population? Maybe it's not so simple. You have to dig deeper. They did, though, look at some countries in Europe and Australia. And they compared the variation there. And in general, the amount of pain that's in the European countries is about the same rate as in the United States. But look at the much tighter data, 12.8 to 18.7 of these DDDs versus in the United States, 7.1 to a high of 165. A lot more variability in the United States. So why is that? And is that something more related to policy and education versus the type of pain? There was some caveats to that, too. If you're interested, I can talk more about that. So Leslie Oakes, who's in our College of Pharmacy, she's a practicing PharmD, has an MPH and a PhD as well. She's been looking at subsets of data from post-surgical pain. And these were total knee replacements. And they were looking at trends from 2006 to 2010. So fairly standardized type of surgical procedure. This was in Maine. And she looked at a subset of patients that had previously not been receiving large amounts of opioids to manage their osteoarthritis, probably related pain in the knee. What she found was, again, variability. There was, at the time of surgery, some physicians writing scripts for less than 30 pills, and others were writing scripts for over 120 pills. That's a lot of variability. More concerning, there was a general trend over time to go to higher pill counts at initial prescription, and the total average amount of opioids being prescribed went up. Even worse, I think, is the standpoint of a number of these people who were not on opioids before the surgery, had the surgery, 3-4 months later, they're still on opioids. So you presume the surgery is going to take care of the pain. Why do they need opioids that long afterwards? Well, it could be that the surgery itself didn't work or maybe induced more pain. There's some evidence of persistent post-surgical pain. You're cutting through nerves, you're damaging tissue, triggering immune responses and inflammation. Maybe that's contributing. Maybe there's some addiction-like properties. So these people who had not previously been exposed to opioids, when they were exposed, started to develop an addictive type behavior. It's not clear. I mean, this is all retrospective data, but it's an opportunity to now start to see, can we design a prospective study, or can we introduce some type of an education program to see, what is our goals? It's not to keep them on opioids after surgery. It's to get them off and getting them mobile and functional again as quickly as possible. That's going to take a team of health care professionals, not just the surgeons and other physicians, but the PTs, the OTs, et cetera. Another thing that's very interesting to us as neuroscientists are the consequences of long-term chronic pain on the brain and long-term opioids. And are there, concerns that are maladaptive or bad for the patient and their outcome, or are there things that are positive? And so this is one summary that I thought was quite useful. It's an overview of clinical and preclinical research looking at chronic pain and cognition. And they're basically saying that the literature examined up to the date, because it's 2013, says that both the preclinical and clinical evidence says pain impairs cognitive performance. And the question is then, how bad is that, and is it permanent? So this is one of their figures, and they try to make the point that there's a lot of different things going on in a chronic pain patient. Pain, and the Neuro Mediator theory, pain is a stressor. We know that things like cortisol go up, there's anxiety associated with it, other stress hormones, so there's a whole biochemical cascade that starts to impact nerves. And nerves are trophic, they're plastic. They constantly change. So then there's the neuroplasticity theory saying that as the chronic pain persists, things can get rewired. Circuits can get strengthened. Think about that bee sting and other things. If you keep repeating something, you get better at it, you learn it. Well, pain is no different than, number of epileptic seizures, an addiction, things that occur. There's something called kindling or sensitization. That might be occurring not just in the periphery, but up in the brain and the spinal cord. Then finally, there's this limited resource theory where the brain only has so much bandwidth. And if you're consuming it and bombarding it with other types of sensory systems, pain, then all of a sudden you can't do other higher executive functions as well. There's just not enough bandwidth for the brain to function at optimal levels. So this may explain in part some of the cognitive deficits that are occurring in a chronic pain patient. Add to that, what type of drugs do we treat chronic pain with? Opioids that can impair cognition, gabapentinoids, and maybe some other ones too that have cognitive side effects. Okay, so they looked at this a little bit closer, and they've got this task that I guess they could do in an experimental situation. It's both a cognitive and emotional decision-making task, and involves these card decks and gambling decisions. And basically, the negative numbers mean poorer performance. If you look at just the blue, the controls, over a number of trials, they get better at making these decisions in this gambling game so that their performance goes from a negative score to a positive score. But if you look at people who have chronic low back pain that are age-matched and everything, they don't seem to learn as well. Right? They maybe go from negative to about 0, but they're not anywhere close to the control group that doesn't have the chronic pain. So again, just one more piece of recent evidence saying, yeah, I don't know how much they looked at the medication history, and that would be a subset analysis, or maybe that wasn't robust enough, but that would be definitely something to look at. Are opioids worse than gabapentinoids versus tricyclics, or whatever other drug of choice? I'd expect that an NSAID might not be detrimental on cognition by itself. And that's the balance there, right? You've got pain that derails cognition, and you've got drugs that might take away the pain, good, but might have their own cognitive effects, bad. With modern brain imaging, too, that's fantastic that we can really get some insights in real time on some of the changes in processing power of the different parts of the brain and see how they communicate with each other. So this is just one study that I think gives us a glimmer of hope, that when they looked at patients that went through I think it was mostly cognitive behavioral therapy to help manage their back pain, they started to see restoration of function that had previously been impaired by the chronic pain. So the brain is plastic, it changes in response to insults, but it can also repair itself to some extent. So that, I think, gives us a big glimmer of hope. So this is some other data that I've been looking at since we were talking, I think you graduated in 2004. I think the first studies that I saw were on people coming into the ER with heart attacks. And what's the standard of care for the pain associated with a myocardial infarction? Morphine is commonly given, along with nitroglycerin-type drugs. They were saying, retrospectively, that the people who came in and got morphine versus those that just got nitroglycerin-type drugs did worse in terms of all outcomes that they measured. And then if you look in Goodman and Gilman, some of the other Bibles of pharmacology, everybody says morphine's cardioprotective and morphine should be given for the pain, relieves anxiety, helps all these different functions related to recovery. The data was suggesting otherwise. Related study, this is now older adults, chronic pain, osteoarthritis, and I think low back pain, and they were tracking those that were on these opioids to look at morbidity and mortality. And if you remember, there was a whole studies with Vioxx. Vioxx was taken off the market. It was a COX-2 inhibitor. It had elevated risk of composite cardiovascular events, strokes, and MIs, along with a couple other things. So, and that was the elevation you'll see. I get the animation to work with the arrow. So elevated risk, it's, the scale is a little bit, from like 5% to 8%. Oh, not a big deal. Well, hundreds of thousands, not millions of patients. That's a big deal. It's taken off the market. Where do you think the opioids fall? Do you think they fall below, in between, above? That's what, I would have probably thought in between. I was shocked. Well above the Vioxx type drugs. And if you look at a bunch of other outcomes in this population, again, retrospective with limitations, falls and fractures, all cause morbidity and mortality, rehospitalizations. There's even osteopenia, osteoporosis is elevated in chronic opioid users. There's an issue here.
What does that excess mean? Months of using a drug?
Yeah, and again, these were retrospective chart reviews, and they track these patients from the, I guess, the initial diagnosis and prescriptions, and just looked at the populations and did they, did an event like this occur in this population? So, yeah, I understand that retrospective studies are open to criticism. They have limitations, but now there's multiple publications similar to this looking at this question. There's finally a prospective study that has been designed. It's being run in Australia, of all places. They feel like this is an important problem and worth investing a large amount of money to properly enroll and follow chronic pain patients. They're going to be looking at rates of addiction and other side effects, including cardiovascular events. And they're going to be doing a lot of other interesting follow-ups with them. But it's prospective. I think it's randomized completely, placebo-controlled. So this will be interesting. I think there's enough of a concern that it should lead to additional studies. And they did some very powerful statistics in this group of studies to try to control for some of the inherent limitations of a retrospective study. Again, not perfect, but it was better than what had come previously.
And this trial is set up to look at the COX-2s.
They examined in their database those who were only on COX-2s, those that were just on opioids. Yep. And again, there's been some other ones, and they're starting to look at biomarkers too. There's a separate kind of translational study that's looking at enkephalin as a prognostic factor for heart attacks after the first heart attack. So there's a lot of opioid receptors. People don't realize there's a ton of opioid receptors in the heart. No one really knows what they do. So we're doing some studies in rats now looking at some of these elevations of cardiac stressor markers in response to chronic morphine. So we can control the experiment a lot better than a clinical study. And so hopefully we'll have some data in the next 6 months to report out.
And the other question is chronic pain in and of itself and all the inflammatory markers that go with chronic pain, is that what's giving you the risk, or is it really these drugs? Yep.
So the MI one, the first thing I asked was, people get opioids. Are they just have more pain, worse heart attack?
Yeah.
They'd be expected to. And that was a serious limitation. This one's a little bit different in terms of the populations, all older adults, and a lot of different types of pain examined, the osteoarthritis population and the chronic low back pain population with variation, that you're just getting the COX, you're just getting, you're managing pain without medication, and you're getting the opioids. So if I haven't already taken myself out of my comfort zone, I'm going to go even farther abroad, and that was this realization. I had never had a real conversation with people in chronic pain, and I think more basic scientists really need to do that. If I can. So this is Paula. Paula's mom wrote me an email after we got our big NIH grant, and she started to tell the story of Paula, and then I met Paula, and we brought Paula out here for a big interprofessional conference. She was a runner, cross country. She twisted her ankle when she was 13, and the pain got worse and worse and worse. She was told by her primary care physician, "You're 13 years old, suck it up." They did everything wrong in this case. They immobilized it. They pumped her full of a lot of different drugs eventually, but at first they didn't believe her. They went to a physical therapist who said, "I think this might be reflex sympathetic dystrophy," something that has been on the books for, I think, since the 1950s at least, related to causalgias and whatnot. It's now retermed complex regional pain syndrome. They went back to another primary care physician who was an old-timer who just said, "I don't believe in those newfangled diagnoses." He then grabbed her leg, sent her through the roof. Talk about bedside manner. We have her full narrative, and if anybody's interested, it's fascinating, the twists and turns. There were successes, too. There was an orthotics person that took the time with her to meticulously shave off little parts of her orthotics to get it just right for her so she could put some weight on the leg. They didn't start believing her until her leg started to swell, turn weird colors, and she started developing these sores. One of the few things that worked for her pain moderately was exercise. She was able to go into the pool and swim, but once she started getting the sores, she wasn't allowed in the pool anymore. She's now in her mid-20s. This was a bright young woman, had the future ahead of her. She can't concentrate more than 5-10 minutes. It was a struggle to, one, come out to Maine to tell her story, and then it was a struggle to just even put together a speech that she gave to all of our health professionals. So courageous, but very sad story. And I'm going to contrast that with a story from Maine in just a minute. Part of narrative medicine, though, is, again, listening to people in our community. This is Sue Gold, who's a writer. She, a number of years ago, I think 25 years ago, developed rheumatoid arthritis when the diagnosis was not so simple, or not enough people knew about it. And she eventually got the right diagnosis and got treated with some of the new biologics that were being developed and had a remarkable recovery. She's fairly pain-free now. She's had some knee replacements, and she's got, I think, a shoulder replacement too. But she describes very vividly, the pain envelops me. It makes me separate from the rest of the world. It was like sailing to a blanket of fog. I lost the fabric of my life. I mean, how graphic, you know, but you only get that if you make her feel comfortable and let her express herself. And unfortunately, we don't have the time a lot of times with busy schedules to, you know, go into a little bit more detail. I love this one. She was getting out of a car one day at the curb, and she was wincing in pain as she kind of got up off the curb. This homeless man who was sitting across from her got up and said, "You look like you're in pain. I'm sorry. I hope you feel better." By the way, he also looked directly in her eyes. First person, her physicians wouldn't look her directly in the eyes. Her family members, who were very supportive and loving, were scared about her chronic pain. They could not connect like this homeless man connected with her. This was someone worse off than she was. She said at that moment, she had this, you know, just epiphany, I got to do something for other people with chronic pain. And she formed a chronic pain support group of Southern Maine. It's based in Saco, and it's helping people like her. It's now 25 years old and doing some amazing things with patients. And we've connected our students with this group so that the students learn firsthand how to talk to a patient. And they're not really patients, they're people, right? How do you talk about difficult things? How do you learn from them insights that make their lives either better or worse during the day? Now, this is even crazier. This is my mom and my son. My mom's had chronic pain for roughly 30 years. She fractured her hip late 70s, early 80s. I was pretty young at the time. She shielded me from it. She didn't want me to be bothered with it or to worry about it. And as she got older, you know, I started to become more aware of it. She luckily had a surgeon that finally listened to her and believed in her. She was telling her, something's wrong with my hip replacement. My hip is not right. She wasn't able to walk with the dog. She wasn't able to exercise. She wasn't able to, she really became anxious, depressed, isolated. Finally, the surgeon went in and said, I can't believe you're even walking. It had degenerated. Couldn't see it on an MRI. We couldn't see it on the CT scan. So here's the family from Maine. Young lady, Amelia. I'm going to show you the video that tells her story. It's about a 5-6 minute video. At least I learned more about chronic pain from this young lady than any textbook that I've written or read. Let me see if I can. The sound's going to work. This was made by our students, by the way.
And I'm a woman, and I was diagnosed with complex regional pain syndrome, or CRPS. Well, in the fall, in like late September, I sprained my ankle playing soccer, and I was on crutches for a few days. I don't think it ever really got better. I just thought it was a sprained ankle, and so I just, you know, treated it like a sprained ankle and then went back to doing activity. But it would bother me periodically throughout the next few months, and then December it just got horrible, and I couldn't walk on it. Like, I went to a lot of doctors. They didn't really understand some of them. They were like, well, we've done an x-ray and it's not broken, and then we did an MRI and we didn't see anything. So they're like, it's probably nothing. It was really frustrating. I just didn't know what to do. Like, it really hurts, and I know there's something wrong. I felt kind of like, almost like alone, that no one really understood it. So I learned how to, like, control myself when I had pain.
You know, I think as a parent, you do doubt when your child won't put weight on their foot. You sort of begin to doubt what's going on and what the child's feeling. And initially, people don't know what RSD or complex regional pain syndrome is. And that's sort of at the basic pediatric care level. I don't think it's something that they see very often.
You know, I always say it's very hard to be the quarterback when you don't know anything about what's going on in the game. Prior to going down to Boston, we were forced to be the quarterback. We didn't have anyone to help us through the process. Because as Amelia's pain got worse, it took more of our attention. And the conversation became all about pain. That's all we talked about in the South. At the first week of it, I listened, and I was just like, can we talk about another thing? I knew that she had pain. She was going to all doctor's offices, so really when I got into school, she wasn't normally there. But really the only time we would interact was at like dinner, and then sometimes after dinner.
I remember it was Martin Luther King Day, so about for this January. And Monday morning, and her foot was flat out purple. And that really started the full court press. Boston Children's had no doubt that she was in pain, and that it was CRPS. I think one of the first things they said in Boston was, rule number one is the pain is real. Just the confidence that that program portrayed in, as soon as you stepped in the door, about getting her off the crutches, getting her off any pain medication. I mean, the steps were just happening day after day.
I think it probably changed my family a lot because it changed like our lifestyle, and because I went to Boston so much, so a lot of the times my mom would be with me and it would just be my dad and my sister here, and I think that was probably hard on us.
Understanding that there are many contributing factors to the pain experience. The physical portion is one piece, but the emotional experience, the family consequence, the emotional correlates are all pieces of someone being in pain. It's called pain and suffering for a reason.
My wife, Sarah, and Amelia lived in Boston while she was in the program full-time. So she was in the pediatric pain rehabilitation program from 8 in the morning till 4 in the afternoon, 5 days a week. Myself and our then 9-year-old daughter, Cassie, were here in Maine, living on our own, eating what I eat, I guess. And, I had to juggle my work schedule, but it was all sort of, once we started seeing progress in Boston, the stress level of juggling those things really sort of went down.
I had like 4 other kids at the program with me that were going through this pretty much the same thing. They knew how painful it was. They didn't think you were faking it or that it wasn't chronic pain or anything. They really understood. I think knowing that other people have the same thing that she had and seeing that they had gone through it, because everyone starts at a different time depending on when the position opens in the program, was very helpful. And just meeting a group of kids who've had similar issues and with a team that knew how to handle this, and it was truly integrated in the practice, the PTs and the OTs and the cognitive behavioral therapists and the pain doctor, they were all coordinated, and that was amazing. At the end of the week, Amelia got her boots. The next week, she started on the cane. At the end of the week, she was walking. And it wasn't pretty, but she was walking.
There's a lot of fear and a lot of anxiety that comes with starting to use a limb again that you haven't used in a long time. And so that's why it doesn't always look pretty. But eventually, as they gain their confidence and their strength and get those normal movement patterns back, which we really, really reinforce a lot here, is normal movement patterns and normal walking, even though it hurts. That's when they become confident.
So Amelia, I first saw her in our outpatient clinic. She was definitely making success because she was very active while she had. So it was almost all active. By the team, she worked through the pain and worked really hard to return to all of her activities, academic and extracurricular, appropriate for her age, and that was really beneficial.
Kids with CRPS have sensitivity to touch in whatever the affected limb is. And so we'll help desensitize that limb, so that way they'll be able to do things like wearing their clothes, play soccer, take a soccer ball, tolerate a shower stream, and be able to take a shower, and do all the things they need to do to function every day. She wanted to get better. She wanted to work hard, and she wanted to work with us. And I was really, really proud of her for that. When I came home from the PTRC, which is the pain program that I went to, I got better really quickly. I think it made me a lot stronger. Like, it made me more, like, tough. I felt like nothing really could hurt me because I went through so much. You can't give up. You just have to keep on working hard, even if it feels like it's never going to get better. It will get better. You'll get better. You'll feel happy and strong again.
I think there's just so many angles to that story. We can bring in social work, the disruption of the family. Best case scenario, right? She is now pain-free. I have some pictures of her last summer, and I keep in touch with the family. They went in front of the Maine Osteopathic Association meeting and talked. She talked to the group of doctors that were there. Very courageous young woman, but no limitations now. She's always at risk for it to come back, but she's got a lot of coping strategies and other things that, if you saw some of the video, had her doing some of her therapies, a lot of occupational therapy along with the behavioral cognitive and physical therapy. No drugs. They took her off the drugs that she was on. And again, I'm worried. I'm an opiate pharmacologist, and I think opiates do have their role in place, but I'm very concerned about their potential side effects, especially chronically. I'm going to finish with my dad, who has more recently, he's going to be 90 in February. He's had some spinal pain, probably around arthritis. He was juggled around to a lot of different diagnoses, subjected to many types of injections and ablations, all of which are discomforting, frustrated, but he had a pain doc that stuck with him. He stuck with her. And eventually, they tried a lot of different opioids. He has responded quite well to opioids, but funny enough, a back brace was one of the other things that helped him. It was one of the last things they tried. So stabilizing the back helped, and a very rarely used opioid. How many of you have ever heard of levorphanol or used it? Clinically available, a little bit difficult to get. It's got a little bit different profile than morphine or oxycodone and some of these other mu agonists. It might have an additional component. It might, for whatever reason, all the other ones, either too many side effects, bowel especially, or just lack of efficacy. Levorphanol is on 2 milligrams a day, and then the back brace. And he went back and got a last ablation under a fluoroscope, and that gave him some relief too, to the point where he can sometimes not wear his back brace. So, it is tough. Just finish, UNE is doing a lot of different things around neuroscience education, K through 12. We do a lot of outreach to the community too, to try to talk about these complex societal issues around health and chronic disease. And we're doing helmet giveaways and all kinds of other things. This young lady is going to speak in front of the entire Thornton High School class. She was a softball player that sustained a very severe concussion. Someone hit her head with a bat. She had to skip her senior season because of it. But she just graduated as an OT. They said she couldn't really go into the master's program right away. She'd take a year off. She persevered and got her OT master's degree, and she's now practicing. Artwork's very important too. I think it conveys, along with the narrative medicine, things that you just can't get in a textbook. And we do all kinds of other stuff too. My last slide, that's my dad looking into his house. They're in their late 80s. They want to stay in their house. That's important to them. They got one of those little Stair-O-Matic things that climbs the stairs now for them. That's helped them. Technology is great. But, again, we have to kind of open our minds, because there's a window. It might be dirty. It might have a screen. You start to lighten the picture, and you see him with his granddaughter, with the TV, with the family, with a home that's very meaningful to him. And so his goals are maybe very different than Amelia's goals were as an 11-year-old. But we've got to look at the big pictures, and that's not just one person's perspective. It's many people's perspectives, including the spouses and the kids and other caretakers and the individual. So again, I know we're out of time. If you guys are interested in more collaboration on these types of topics, education, clinical research, outcomes research, we're very much interested in partnering with people. Thank you.